err on the side of peritonitis, but you can investigate. What can you do more to find out the other reasons that Dr. Ramanu just mentioned? That's why we are here. What more you can do? See, we are trying to extrapolate a case into many cases, which is what we are trying. So therefore he asked you. Not that he has a doubt it is peritonitis. You're getting the point? Okay. You're asking, sorry. A malaise can be raised in peritonitis. Any other?
What medications do you avoid in this patient? Or do you?
We need a diagnosis. Let's stick to the diagnosis first, no? Now, what can be done more? If nothing can be done, say nothing can be done. Don't just stand there. Anything more? Yes.
See, on this.
No,
doctor-
let them speak their mind, then we'll discuss. Anything else? He said peritoneal lavage. You said so? First of all, lavage is not done. There's nothing like peritoneal lavage. And you don't put needle in anywhere, okay? And you should be absolutely blinded, or you should be blind to do those kind of things, because these are out of use now. Reason being, they're invasive. Two, negative means nothing. You can keep poking left, right, and center. You should have asked the radiologist more about the ultrasound features. I am trying hard, and you're not answering that part. Ask questions. What more? Like you mentioned about gas, you can see gas on ultrasound. Who says you can't see? Whatever is seen on X-ray can be seen on ultrasound. You need a good sonologist to do that. I'm extrapolating. Pancreas is not seen well, but you have indirect evidence of, he'll tell you about the fluid also. What kind of a fluid is it? That's why the points were raised. If it is the fluid suggesting peritonitis, you will be able to make a diagnosis. The amount of gas also helps you in making a diagnosis. If you still can't make a diagnosis, this is perforation peritonitis unless proven otherwise. That is how you approach. This is not a case where you can do CT and, yes, you were saying something. You've done ultrasound, it's all ruled out. He is not saying it that it will happen. He's trying to say there can be blood, there can be bile, there can be pus, there can be... Yes. So this is what we are discussing.
Even a bad cholecystitis can have similar features.
And bad cholecystitis can, perforation of gallbladder, we have seen and operated, it happens.
Yeah.
Now this according to you is the case because we have limited time to do everything. It can be anything.
Yes.
Science is never absolute, so it can be perforation peritonitis. Let's not go away from it. Huh?
No, we are not going away from it. Regarding ultrasound guide tab, I just wanted to give my opinion that ultrasound is a very subjective procedure. The questions we are asking may not be answered by the ultrasonologist, but ultrasound guided done tab would help in deciding what kind of fluid it is.
Go by the clinical scenario of the recent 2-3 days history of pain, vomiting,
Surprise,
and then
actually.
this finding, then we should not resort to ultrasound guidance, rather than you should plan for
See,
doing
and
a
actually
early
it's not about
laparotomy.
Maninder, it's not about how we feel, it's not recommended. And the problem is you are introducing infection, or if it is a clean ascites. Okay, you may sometimes be able to make a diagnosis. That's why I was asking about peritoneal lavage. It is not always diagnostic, a negative means nothing. Okay, and you can talk about it, some examiner may like it, so you can agree and disagree. Your diagnosis is perforation peritonitis, how do you proceed? We have to move, no? You don't want to proceed? Oh. He says, I won't go. Now his hand over. What is optimization here?
Please take the mic.
Correction.
No, that can be a point.
Hydration status correction, and also taking the obstetric consultation at the time.
Very good.
For any other optimization from their side also. And in the OT, we will be like to have the obstetrician available also.
Excellent. Can you do something less than laparotomy to find out before you go in for
And
opening?
don't omit antibiotics also here.
And you'll give antibiotics as you
Antibiotic, pre-operative antibiotic cover, and also intro.
What antibiotic should avoid? What antibiotic should avoid in this situation? Patient having a misdiagnosed pregnancy?
Gentamicin and fluoroquinolones and aminoglycoside also.
On aminoglycosides. Fluoroquinolones also should be avoided. Anyway, we were answering that. So you made a diagnosis. Can you do a diagnostic laparoscopy in this?
Being a second trimester, we can go for the diagnostic laparoscopy also, sir.
It will give you a diagnosis. I think that's a very valid point. And rather than doing a diagnostic laparotomy, you can do a diagnostic laparoscopy.
Sir,
And you can actually find out the cause, you can get lots of fluid, you can give a lavage, you can put a drain, you can do so many things. That's a useful. And it is safe, because you're second trimester. That could be in the algorithm. You don't handle the tissue, so you don't produce eye layers, you don't cause damage. So it is indicated. And it is safe. You can actually fix the problem also with diagnosis, with the laparoscope, if it's just a perforation. Now, we will stick to what normally the questions are asked. So these are options. We were just extrapolating. Correct? Now, this patient was in distress and had to be taken up by the case of perforation peritonitis. Is that clear? How would you approach next? What was done, we'll tell you. You would like to answer? So you decided diagnostic laparoscopy reveals a ileal perforation. As we were discussing about the typhoid perforation, it's in the terminal ileum. Proceed. Go back. Don't give an idea.
After if we on the
We
diagnostic.
opened up. There is
Opened up.
there is perforation peritonitis from bowel, ileum, 2 days old, enteric.
Considering it to be as a 2 days old, and also the possibly there will be high contamination, as we have already taken the stoma consent, we'll be taking the patient for the stoma. Most probably a loop ileostomy will be planning for.
Anybody else? This is a blind answer. You know, pass it. When you don't answer, pass it. Don't waste time.
So I would like to know the amount of contamination present.
He says more. You can say less. Somebody else will say beach mein. Somebody would say
And I would like to know the vitals intraoperatively.
vitals. We have been told. They have been told already.
Intraoperative, on the table.
On the table, they won't change as soon if you take up in 2 hours.
Now on the table, say for example, there is a hypotension. So how does it change?
No,
things?
we're not changing. We're not
No,
making that.
so-
Hypertension is not there. This is the case. How do you decide whether you need a stoma or you don't need a stoma? This is a very casual reply. Everybody gives it. Contamination,
So we
ILC.
can use scores like Apache.
Yes, so come to the point which is solid and you get an mark for it. There are guidelines to stick to. So you'll score this patient. How do you score it? What is Apache?
So Apache is acute physiology and chronic health evaluation.
How many variables are there?
Yeah.
12.
How many are acute? How many are chronic points? Anybody? Can you answer? 12. What are those 12?
So vitals, the blood pressure, the pulse rate, the temperature, the total leukocyte count, and then we look at the ABG also, and
Chronic would be age
age.
and you forgot the GCS, which is also included in Apache. But Apache 2 is a good landmark. Use some score. You can't just say, I didn't like it. It was like when I was in doubt, so I took it out. That doesn't work. Anyway, this patient was taken up, and you can see the score is not going to be good. And how do you decide based on score when you do primary closure, when do you exteriorize?
So if the score is less than 10,
What do we do? We have a long back, we had a publication that we practice that routinely. What is the score that we look at? Less than 10, primary closure. 11 to 20, exteriorization. More than 20 is not fit for any surgery. Bilateral flank drains, resuscitate the patient, optimize, bring it down to group 2 and do exteriorization. This is how you approach it. And when you do a stoma, this is, can you move to the next slide, please? This was done. Right or wrong? This is it.
Exploratory laparotomy with primary repair of the perforation with proximal loop ileostomy with bilateral flank drains under GA. And the intraoperative findings were a 0.5 into 0.5 centimeter perforation was found in the terminal ileum, which was 1.5 feet away from the ileocecal junction. There was gross fecopurulent contamination of the peritoneal cavity around 1 liters.
Here there is no confusion. This case only last week, so that's why we put it up today itself. And the decision, we wanted to know the decision about stoma. Can you go back? Yes. When you've done a stoma, what other things you do? Somebody else can also take it. You take it. You can stand. Yes. You've done a stoma because you suspect there's contamination. It's going to open up. How do you take a decision about closing the abdomen? If you don't know, then please don't think about it. No? There's no time. That's how we lost the day. The vascular session took hours and hours. We finished a lot of time there.
Since there was a contamination, I'd like to do a single layer closure.
What is single layered closure? Single layered closure? What is that closure?
The rectus sheath and the muscles.
What is mass closure?
Sorry, mass closure.
What is mass closure? When you don't know, how will you do it?
Do you expect that this patient might have
Do you think it's close?
post-operations?
Do you think this is an abdomen you would close? You thought you are giving me as a plan B, if this is a contamination, so I'll do single layer closure. It happens, I tell you, the closure of abdomen is what they won't learn. They know about laparoscopic ting tong here and there, but the basic closure you wouldn't know. What is mass closure? Quickly.
So, when the abdomen is closed by a single,
What are we closing actually?
we close the rectus
Sheath. Only the sheath,
Only the
linea alba.
sheath.
What distance? How far?
It is 1 centimeters from the margins, from the edge of the incision, and 1 centimeter distance
Not more
between
than 1 centimeter from the previous bite.
Previous bite.
And we take inside, or we start from, when you're suturing from right side, how would you start?
From above downwards.
Above, downwards, because you're right-handed. So inside out, outside in, you take it.
Not
If you're in the
inside.
loop, you come out and then 1, 1, 1, 1.
Without
It is
locking.
based on which rule?
Jenkins rule.
Jenkins rule of mass closure, which is a spring coil effect. What is the spring coil effect theory?
So that we do not lock in between, and with the single suture we close the entire.
It becomes a
rectus
spring
sheath.
coil.
It becomes a spring.
So it can uncoil during post-operative period and come back. So burst abdomen rates are low. This is the spring coil effect theory of Jenkins, given in 1986, practiced now all over the world. Mass closure technique. Interrupted closure, locking sutures, they are no longer recommended. Clear? And at the end, with what knot you finish at the end?
Aberdeen's knot.
You finish with the Aberdeen knot, which is called self-locking knot. Okay? So there is a system. But here, would you close the abdomen? You sit
No.
down. I think yes, Sunil. You close or don't close? How do you take a decision? I'm sorry? Can you give the mic back? The score would be, I think it is 14.
I would like to close.
No.
You'd like to close, she wouldn't like to close. How many would like to close? You only learn what you watch. Now they know it shouldn't be closed, so they're not raising their hand only. The one in red shirt. What is the basis of decision? How do you make that decision? So what criteria should be used? Yes, you said we won't close. Why?
So because intraoperatively there was contamination, fecopurulent contamination, and also we would like to have a look on the bowel. If it is not healthy, then again.
No, it's again you're pushing it in, and you can measure intra-abdominal pressure on the table itself.
Sir,
If the pressure is high and you're closing it forcefully, it is going to burst open.
Right.
And burst abdomen is not something that you can say, okay, if we leave it open or the abdomen opens, it's the same thing. The physiological damage would have already happened by the time you take that decision. And I'm telling you, maybe this doesn't happen at your place. You don't close abdomens which don't close. Simple. Because burst open, they've already produced the physiological damage of abdominal compartment syndrome. What is abdominal compartment syndrome, Sunil?
So when the intra-abdominal hypertension is more than 20 millimeters of mercury.
That's not abdominal, that's intra-abdominal hypertension. That's not abdominal compartment syndrome. Next.
With organ failure.
With?
Compromise of
With?
Organ failure.
One organ failure. Anyone.
At least
So
one.
intra-abdominal hypertension and minimum of one organ failure. How would you make that diagnosis? What is the first thing you observe bedside?
So respiratory
Bedside, I told you.
decrease.
Urine output. So intra-abdominal hypertension with oliguria. You think of abdominal compartment
Sir.
syndrome. What do you do for that?
So I would like to measure the intra-abdominal.
Measured, I've told you. I've told you the pressure. It's high. Decompressive laparotomy. You have to do. So therefore, these are not closed. What have you heard of decompressive laparotomy? Yes or no?
Yes.
So what kind of a preparation you need for decompressive laparotomy? Anybody? I'm asking her as well as all of you. What is the problem when you decompress the abdomen? What is the problem in any compartment syndrome when you decompress?
The bowel will be.
Reperfusion injury. Who is this? Yes. What is reperfusion injury? You're correct.
As there are generation of the free radicals already, as the blood flows after the release of the pressure, there is circulation of the free radicals.
Excellent. So how do you prevent it? Keep standing. You answered well. You have to prevent, no? So what do? Take the mic. Any one of you? 5. Those 3 behind. Anybody here? Here? What is decompressive cocktail? This is exactly the water round question that I'll ask you. Decompressive
bicarb.
cocktail is?
Sodium bicarb with.
No. Soda bicarb, yes. And? Mannitol?
Mannitol.
And a liter of saline. Because what is happening is the moment the decompression happens, there is splanchnic pooling and it's cut off a blood supply to the splanchnic system. So you need to replace with fluid. Second thing, the kidneys don't function because of pre-renal shutdown. So you give diuretics to clear it off. Third, there is acidosis. This is the triad that kills the patient. So you don't decompress also suddenly. You must have noticed, I think you operate in the night in the emergency. You don't talk to the anesthetist maybe. Every time that you do a laparotomy for these cases, if you ask the patient, the anesthetist will say the saturation is improved. Because there is always some element of intra-abdominal hypertension in all these cases.
Sir.
So therefore we must measure the pressure.
Sir,
Yes?
can I add, sir, just 2 things. Number 1 is that when now someone asks you about this management of any abdominal sepsis, appendicular thing, peptic, just add 2 words: source control, peritoneal lavage with a normal saline. So please remember that peritoneal lavage. Number 2 is that will you close the abdomen or not? There is a grading of peritonitis called as Mannheim's
No,
grade.
that doesn't work in closure. MPI grading doesn't work now in closure, please.
In
That is
peritonitis.
why it is important. In
Sir,
peritonitis closure, I'm sorry, I'm stopping you for a reason. The MPI index, MP index is not used for deciding about closure. It is used
Sir,
for deciding about sepsis.
Sir, for closure, sir, number 2 is that the World Journal of Abdominal Compartment, this something came up with. Number 1 is the Apache. Number 2 is the on table, the abdominal compartment pressure. If the pressure is really more than 15,
exactly what we
you
discussed.
should go by a temporary abdominal wall closure, only the skin. Number 2 is that in the post-op 12 to 24, if there is on monitoring, there is a rise. At bedside, you should go, as sir has said, about a decompressive laparotomy. Number 3, if the IAP is said to be more than that, or with presence of gross bowel edema, better go for a laparoscopy or a Bogota on that case.
वही तो कह रहे हैं, तो repetition. MPI is one of the indices. There are about 34 of them. The one which is workable in a clinical scenario is Apache 2 and 3. 3 is cumbersome, so 2 is used. You can take a decision based on not only sepsis, but also based on intra-abdominal pressure, which is said you will measure on the table. The rule of thumb is if you don't have any of these facilities, when you put the bowel inside, if you see even one loop outside, you should not close this abdomen. And if there is doubt, as Ramanuj was saying, leave it open. There is no question of closing anything. But there is a problem with that, evisceration. Some people like to just close the skin. But releasing it once the pressure has risen has its morbidity. Okay? And laparoscopy is a very reasonable method of managing it. Laparoscopy means leaving the abdomen open. I was going to come to that after this. And like you said, peritoneal, what do you use for peritoneal lavage?
Saline.
You can answer, no? You have to answer anything right or wrong.
We use normal saline only. Earlier we used to use the warm salines, but it has been found
Normal
that it is
saline.
no.
And what are the disadvantages of a lavage? Sunil? No. You can use a little lukewarm saline, nobody minds that in winters. If you do too much of lavage, which somebody was referring, you can wash away all the opsonins. So it does harm. Initially, just get the debris out. Is that okay? And lavage is not something which is very popular with people in the West. They don't use betadine, they don't use Metrogyl. These are not used. I'm coming to the point where Ramanuj was starting. You can use any score. The idea is for you to say in the exam that I won't close an abdomen just like that. It's a tendency. And burst abdomen